Hello, everybody, and thank you for coming and joining us tonight. We're going to wait just a couple of more seconds and a couple of more minutes while the rest of the people join tonight's webinar, and then we'll go ahead and kick tonight's event off. So if you just stay patient with us for a couple of moments, we will be underway shortly. Very well done. It's about to strike 5:30, so we'll go ahead and kick this thing off. And thank you, everybody, for joining us tonight for tonight's webinar. My name is Michael York, and I'll kind of be your moderator for this evening. We are fortunate enough to have Dr. Sonia Dhoot presenting on diabetic retinopathy tonight, which is exciting. And at any point during tonight's presentation, if you have any questions, please do feel free to enter your questions into the chat function below. We want this to be an interactive experience. So as the questions come in, I'll be happy to go ahead and read those for Dr. Dhoot aloud, and she'll be happy to take those questions as we go along. Before we get started, a little bit more about Dr. Dhoot. She received both her undergraduate and medical degree from the Rensselaer Polytechnic Institute and Albany Medical College in New York. After her schooling, Dr. Dhoot interned at the Arrowhead Regional Medical Center and then proceeded to complete her residency in ophthalmology and 2 years of vitreoretinal surgery fellowship at the University of Missouri and acted as chief resident in her final year. So without any further ado, I'll hand the baton over to Dr. Dhoot.
Thank you, Michael. And thank you to all of you joining us this evening. I am very happy that you chose to join us this evening, and I'm hopeful that next time we do this, we can do it in person. It's very weird staring at a computer screen, and I would love for this to be as interactive as possible. I want this to be a really casual conversation, so please, if you have any questions, any input, go ahead and type it in the chat box, and Michael will interrupt me in between slides, and we can keep this as interactive as possible. Diabetes is something that affects a lot of Americans, but can be kind of dry. So I'm trying to keep this as interactive as possible, and feel free to interrupt. So with that, we'll get started. I do have a disclosure. I am a paid consultant for Alimera Sciences and Glaukos, although that's not really relevant to today's talk. So what is diabetes? Diabetes is a disease where our blood glucose levels are too high, and there is a number of reasons that that can happen. So there's insulin, which is made by our pancreas, and that helps glucose get into our cells for various functions all over our body. In diabetes, for whatever reason, the body's unable to get those glucose into cells, and that can either be because we don't have insulin, or we have insulin, but our tissues are what we call resistant to insulin. So the insulin is there, but it's not working as it should. So as a result, the glucose stays in our bloodstream, and it can affect the organs all over our body. There's type 1 diabetes, which means we're born with a lack of insulin, basically. There's type 2 diabetes, where we have insulin, but our cells are not able to receive the insulin because usually of a damaged receptor, and so end up having elevated glucose levels. And then there's different autoimmune types of diabetes, which are much less common. So the diagnosis for diabetes, there's a couple of different ways we can make the diagnosis. There's something called a hemoglobin A1C, which is basically a test of what our average glucose levels have been over a 3-month period. And that's a really important number that primary care doctors, endocrinologists, and even ophthalmologists will use to kind of track to see how your diabetes level has been kind of trending. You can also do a random blood glucose level, a fasting glucose level, and then oral glucose tolerance test, which we often use for patients who are pregnant. So, like I said, diabetes can affect all of our body, our heart and our kidneys, our peripheral nerves, our GI tract. It usually starts with the small blood vessels in our body. So the nerves in our feet, which is why people get nephropathy or neuropathy, meaning they can't feel the sensation in their feet. The kidneys, which is what we call nephropathy, and in end stages of diabetes, people sometimes have to be on dialysis. And then the heart and the brain. In the eyes, it's just unique because we have the ability to actually see that damage early on. So diabetic retinopathy, the retinopathy basically just means that the diabetes has affected the retina, which is the nerve tissue in the back of the eye. So it's a broad term that we use for all abnormalities of the retina that's caused by the diabetes. So it includes the blood vessels becoming weak, the blood vessels leaking, and in really late stages, formation of new abnormal blood vessels that can cause a lot of problems that we're going to talk about in a minute here. So diabetic retinopathy is the leading cause of blindness in individuals between the ages of 20 and 74 years of age. It's responsible for about 12 to 24,000 cases of legal blindness every year in the US. And the really important thing is that almost all cases of severe vision loss can be prevented if we catch it early and are able to treat it. And the scary thing about diabetic retinopathy is until it's in the really, really severe stages, most people don't even know they have any disease. So what are the symptoms? Again, these are symptoms that people usually don't have until much later in the disease. But sometimes people will complain of floaters, blurry vision, fluctuating vision, blank or dark areas in your field of vision, poor night vision, color vision being affected, and then just overall kind of feeling this sense of losing vision. So what are the risk factors of diabetic retinopathy? The number one thing is how long you've had diabetes. We know the longer you've had it, the more prone you are to developing diabetic retinopathy. In type 2 patients, if you've had diabetes for 10 years, there's a 50% chance you have some degree of damage to your retina from the diabetes. And if you've had it for 30 years, that number goes up to 80%. So we know that the control of blood sugar prevents the delays the onset and slows the progression of the retinopathy. There are some other things in your body that increase your chance of having retinopathy, and these include pregnancy, high blood pressure, and then the other ones listed. But pregnancy and high blood pressure are the two that we see most commonly. So screening guidelines say that in type 2 diabetes, the first exam is recommended within the first few months of diagnosis. And the reason for that is because with type 2 diabetes, we often think that when you're diagnosed, it's like you've likely probably been diabetic for a little bit before your diagnosis. And so it's always important to get that first exam in to see kind of how things are going forward as soon as you're diagnosed. And approximately 1 in 5 patients with type 2 diabetes already have bleeding in their eyes at the time of diagnosis. And that's, like I said, because they were likely diabetic even before they were diagnosed. And then, like I said, even if you don't have bleeding in the back of your eyes, it's very important to get at least a yearly dilated exam because retinopathy can be asymptomatic. So the clinical classification, if you have diabetes and you see one of our retina specialists, you've probably heard us talk about this quite extensively. So there's two big classes. There's non-proliferative diabetic retinopathy, also known as background diabetic retinopathy. And that includes something called microaneurysms, macular exudates, and ischemia, which just means reduced blood flow. And I'll show you pictures of all of these things in just a minute here. And then the second umbrella term is called proliferative diabetic retinopathy, and that's much more severe. And that includes all of the findings of the non-proliferative stage, along with something that we call neovascularization, which means new blood vessel growth. So non-proliferative diabetic retinopathy, there's a couple of pictures here on the right. And those little yellow circles, it may be really hard to see because they're really tiny. And, you know, early on, they are very tiny and difficult to see. But if you look at the black and white photo, you can see those little white dots. And those are examples of microaneurysms. And basically, the small little blood vessels, the capillaries in the retina, basically start getting larger. And that's kind of one of the early signs that we see that, you know, there's changes in the blood vessels, and most likely you're going to start bleeding more. When you start having those bulges in the blood vessel walls, all of the stuff that's supposed to stay inside the blood vessel, protein, fat, fluid, they all start leaking into the retina, and that's when we can start having problems with our vision. So exudates are these little yellow things. They're much easier to see. And that's fat that's supposed to be inside the blood vessels. But because those blood vessels are damaged, that fat basically burps out into the retina. And we see it as those little yellow spots that we call exudates. So when blood leaks, it looks like a retinal hemorrhage. And there's spots of little red hemorrhages here in this picture. And then when fluid leaks, we get what we call macular edema, and that's swelling of the central retina. And that's usually when you start noticing that your vision is blurry. And then when protein and fat leak, that's when we get those yellow things called exudates.
So it does look like we have our first question of the evening, Dr. Dhoot.
Okay.
And that is kind of a two-part question, actually. Can you explain the consequences of cupping of the optic nerve? And then the follow-up to that, if you're diagnosed with type 2 diabetes and your A1C drops to non-diabetic levels, is the diabetes reversed in that situation?
So good question. The optic nerve cupping basically just means that there is damage to the optic nerve. Sometimes that can be related to diabetes, but that's not until the end stages of diabetes that we see damage to the optic nerve. And I'm actually going to talk about that a little bit later. It's a phenomenon called neovascular glaucoma, meaning your proliferative diabetic retinopathy has basically gone so far that it has caused severe glaucoma. And so that's one of the severe cases of diabetic retinopathy. Now, the second question about reversal of retinopathy. Retinopathy is very difficult to reverse. And so certainly the way that your sugars were 2 years ago is really what affects your eyes now. And so with local treatments to the eye, and then controlling your sugars will probably prevent things from progressing down the road, but reversal is really difficult to do. So I hope that answers the question. I'll discuss a little bit more. There's some studies that have looked at that, and we'll discuss those a little bit more in a few slides here. Anything else for right now?
And then, so just to clarify, it's not the reversal of the retinopathy, but could it be determined the reversal of diabetes?
I don't understand the question. You mean, can you basically become not a diabetic anymore?
Correct. Yeah. If your A1C drops to the non-diabetic levels, it has the diabetes reversed, essentially.
Yeah. So I actually have a few patients that were on insulin, diabetic, really high A1Cs, and they changed their diet. They lost a bunch of weight. They got their blood pressure under control, and their primary care doctor or their endocrinologist actually took them off of all of their diabetic medications. So if there's damage in the eye, then that's less likely to reverse. But absolutely, I have a few patients who've basically gotten the diagnosis, gotten their life on track, and they've been able to get off of their medications. So absolutely, and that's a decision that would have to be made closely with the endocrinologist or the family doctor that's managing the diabetes. Okay, so non-proliferative diabetic retinopathy. So we're talking about the retinal hemorrhages, the exudates, and the macular edema. All three can cause decrease in vision, but particularly macular edema. And on the right here, the bottom picture is a scan of the macula. And all these little black bubbles here, those are all what we call macular cysts or fluid, and that's macular edema. The more swollen the retina, the more blurry the vision. Sometimes more in the advanced stages, blood vessels in the macula can actually, because they're so small, get completely closed off and not receive any blood. And that's what we call macular ischemia. And unfortunately, that's more difficult for us to treat. We can treat the new blood vessel growth, we can treat the macular edema, but when we get to the point of the blood not flowing through the blood vessels properly, that becomes harder and harder for us to treat, and goes along with the fact that we need to monitor all of this much sooner. So I just have some pictures here for you guys to look at. This is what we look at, what we see when we look in the back of eyes. So this little yellow circle here, that's the optic nerve. That's like the cable that connects the eye to the brain. And just next to the optic nerve is what we call the macula. And you can see in this patient, there's lots of hemorrhages, few little what we call exudates, and most likely swelling here in the macula, as well as lots of bleeding and hemorrhages over here by the blood vessels. Here's another patient, optic nerve and macula, and less hemorrhages than the last patient, but this patient also likely has macular edema and non-proliferative diabetic retinopathy. Here's yet another picture, more exudates, and this patient most likely has edema as well. So to kind of recap, non-proliferative diabetic retinopathy, combination of leaking, swelling, and reduced blood flow all cause decreased vision. So we can actually, so the leaking and the swelling we can see when we look back there, but the circulation itself is difficult for us to appreciate with our naked eye. And so we often use something called a fluorescein angiogram, where we inject some dye in the vein in your arm. And then as that dye travels in all the blood vessels in the body, we actually take pictures as it travels in the blood vessels in the back of the eye. And that gives us a lot of information as to what's going on with the blood flow in the back of the eye and how much ischemia is there. The dye is a non-toxic vegetable dye. It's kind of like food coloring, and it's not like the contrast dye that many of you may have had for CTs. So it does not damage kidneys, which is a common question we get. So having liver or renal disease is not a contraindication to doing the angiogram. And these are just pictures of the angiogram. We get black and white photos, and all of these areas here where there's white that look kind of blurry, that's the dye leaking out of the blood vessels, which, like we talked about earlier, we know happens in patients who have diabetes. And here's a patient, you can see there's more of that kind of white, fluffy, cotton-looking stuff, and that's all that stuff that was supposed to be inside the blood vessels kind of spilling out into the macula. The other thing we can use is something called OCT, which stands for optical coherence tomography. If any of you have seen a retina specialist, you most certainly had this done. It generates a cross-sectional image of the retina and allows us to look at the 10 layers of the macula very closely. There's no needles, no injections. It's very easy to perform in clinic. And it's good for following edema over time once we initiate treatment to see how well and how successful the treatment is. It's less variable and less subjective than a fluorescein angiogram because it actually gives us thickness measurements. And so we can use those numbers to see how well someone is responding to treatment. So this is a picture of the OCT machine and some of the images it generates. Both of these patients have macular edema. The patient at the bottom here, as you can see, the macula is more swollen than the one above. So although they probably both have complaints of blurry vision, the patient down below probably is much more severely impacted by their vision because their edema is much more. So the role of the medical doctor is to control the systemic factors, the blood pressure, the blood levels, the fat and cholesterol, anemia, renal disease. And because all of that has been shown to reduce the risk of progression of diabetic retinopathy. So I'm not going to spend too much time on these studies, but they're here in case anybody has questions about them. Basically in medicine, you know, we can't just say, hey, we think your blood sugar or your blood pressure reduces the risk of damage to your retina. We actually do studies to go through all of these things to actually prove what we recommend to patients. And so this study was originally done that said, hey, in type 1 diabetics, if you take insulin and you control your blood sugars, the risk of you developing diabetic retinopathy decreases by about 75%. And if you have retinopathy, the chances of your retinopathy going to the proliferative or the advanced stages reduced by a half. And then they basically did the same study, but in type 2 diabetics and said, okay, well, in type 2 diabetics, if you control your sugars, you have reduced microvascular complications. And that means diabetic retinopathy, diabetic kidney disease, diabetic heart disease. It reduces the those complications by about 25%. And for every 1 point that you go down on your hemoglobin A1C, reduces the risk of your microvascular complications by about 1/3. And then this study, the Wester study, basically looked at, okay, well, let's control everybody for the same level of sugar. If we control blood pressure more tightly in one group versus the other, does that help? And absolutely, we know that controlling your blood pressure also helps your degree of retinopathy in both type 1 and type 2 diabetics.
So we have one more question that just came in, Dr. Dhoot, and it's from somebody that is new to Harvard Eye. So first and foremost, welcome to Harvard Eye and welcome to the family. The question is, I have type 2 diabetes. Would one start out with one of our optometrists that we have on hand, or should they go immediately to one of our MDs as the person has done in the past?
Yeah, I mean, honestly, either way, it's if there's any bleeding at all from the diabetes, the optometrists will get you in to see one of our retina specialists. But I have patients who don't have any bleeding in the back of their eyes that I monitor as well. So whatever you feel comfortable with. If you already, maybe need a glasses prescription, you can start off there, and then make your way up if needed, or you can come straight to one of our retina doctors, whatever you feel comfortable with. And welcome to Harvard Eye. Anything else, or?
Nope, that is it for now.
Okay, so then, then they did another study that basically said, okay, well, what about controlling cholesterol? And big surprise, elevated cholesterol levels are also associated with decreased vision and more severe retinopathy. Diabetic nephropathy. So nephropathy means damage to the kidneys from diabetes. And so we know that patients with kidney disease are anemic, and so they lose protein in their urine. And protein actually is what keeps fluid inside the blood vessels. So if patients are losing protein in their urine, that's less fluid that can be held within the blood vessels, and then that fluid leaks out into the retina, causes macular edema. And so patients that have kidney disease from their diabetes, we know that they do much, much better when they go on dialysis if they need it. So what is the role of the ophthalmology team? So we obviously specialize in local treatment for the eye to get your vision restored. There's times that we will do laser treatment to the eye. There is injections of medication into the eye. And so with the injections, there's two different classes of injections we can do. One is something called anti-vascular endothelial growth factor, which is a really fancy term of saying we inject something that basically stabilizes the blood vessels and makes them stop leaking. And then the second thing we can do is steroid injections, either around the eye or directly into the eye. And there's a few different steroids we can use. And the thought process behind the steroid is that basically it helps cut down the inflammation. We know that diabetics have a higher level of inflammation in their body. So we know steroids kind of help with that aspect of the diabetic eye disease. So the different steroids we can inject is something called Kenalog, Triessence, or Ozurdex. There's also a new drug called, well, relatively new, came out in 2015, known as Eluvian. And then in some severe cases, we need to do surgery. So let's talk about the different type of lasers we can do. So for macular edema, we can do laser to actually seal those microaneurysms that we talked about earlier. And it basically just seals it off and prevents it from leaking into the retina. And obviously, if there's less macular edema, we know that reduces the risk of vision loss. And this is another picture of a patient who has had what we call focal macular laser. And can you, Michael, can you see my cursor or no?
I can, yeah.
Okay, perfect. So all of these little spots here, if you guys can see them, those are actually laser scars. And so this person had all of these microaneurysms here that were lasered to prevent progression of the edema into the macula. So what are the advantages and disadvantages of the laser? Well, the advantages is it works. You basically seal off those blood vessels. It stops them from swelling. It's quick. It's done in the office. It's very comfortable. We put a numbing drop in the eye and we laser it. Patients are pretty amenable to it. It sounds pretty cool. I can laser your eye and you'll see better. I mean, you know, it's an easy concept to sell. The disadvantages is every time we create a scar with a laser, it creates a scar, and that's a small little blind spot. And, you know, if you do it very gently and far away from the center, most people won't notice that blind spot. But over time, if you have a lot of those lasers and if they get closer and closer to the center of the vision, well, then over time, that can actually reduce your vision in the areas that you've been treated. Back maybe 20 years ago when we didn't have access to the injections that we have now, this was kind of all we had. And so, you know, it was kind of the only option. But now we have all of these anti-VEGF drugs and steroids that we can inject into the eye without creating a blind spot. So these VEGF drugs are actually chemotherapy drugs. So the main one that we use is called Avastin, and that actually started out as a chemotherapy drug for colon cancer, because just like in the eye, in cancer, you know, cancer requires lots of new blood vessels to grow. And so a lot of chemotherapy agents target those new blood vessels. And this specific anti-VEGF drug didn't really work very well for colon cancer, but we started realizing that people were seeing better. So it's basically the same drug that was reformulated and packaged in individual vials for us to inject into the eye. And so the anti-VEGF works for macular edema, and it actually plays a role in the formation of abnormal blood vessels that we see in later proliferative diabetic retinopathy stages that I'm going to talk about in a little bit. So this is a picture of somebody getting an injection. For those of you that have never had them, never heard of them, they sound god-awful. Patients tremble when I tell them they need an injection, but afterwards they're like, that's it, we're done? I mean, the thought of it definitely sounds way, way worse than the actual procedure itself. I kind of talked about kind of its history. There's 3 anti-VEGF drugs available for diabetic eye disease right now. Avastin, like we talked about, Lucentis, which is kind of brand name Avastin, if you will, and then Eylea or aflibercept. So Avastin, in 2021, most people would consider this the standard of care for diabetic macular edema and use this drug first. It's used for patients in wet macular degeneration. Initially, that's what it was used for, and then vascular occlusions, and then diabetes. And it's not FDA approved, but Medicare has been reimbursing us for this drug since back in 2009. And the drug itself is about $200 per treatment. So the advantages, like we talked about, there's no laser scars, so no damage to the retina. It can treat large areas of swelling. So if you have a lot of swelling, it would be really tedious and probably not a good idea to go treat every single tiny little blood vessel with a laser. Whereas if you do one shot, it can kind of broadly treat that huge area of swelling. It's easily done in the office with minimal pain. Usually we numb up the eye pretty well. And for the most part, you know, it works, it provides pretty rapid improvement in edema and vision. It's very rare that it can cause an increase in intraocular pressure or glaucoma. Bottom line, it works and it's cheap. The disadvantages is that it's not FDA approved. So occasionally it can be difficult to receive private insurance reimbursement. That's less so of an issue now because the other drugs are much more expensive, so they would much rather pay for the Avastin. Anytime we do an injection, there's a risk of infection like any other injection. That risk is about 1 in 2,000 to 3,000 people. There's a history of controversy because there were thoughts that the Avastin that they use for chemotherapy, which is obviously very different because it's higher doses, it's being put into the IV as opposed to just directly into the eye itself. But there was thoughts that that could lead to strokes or heart attacks. They have done lots of studies since that's shown that there is no correlation between the two. And then the other disadvantage is that it works, but it's like any other medicine, it wears off. And so usually about 4 to 6 weeks, 4 to 8 weeks, if you're lucky, we have to keep redosing the medication. There was a class action lawsuit against Avastin back in 2018 because there were some silicone bubbles that were in some of the pre-filled syringes. They were harmless to the eye itself, but people were noticing floaters. And so now, since then, they have made silicone-free vials of Avastin, which is what we use, of course. So Lucentis, basically what happened when this Avastin drug got switched from a chemotherapy drug to an eye drug, they took basically, without getting too molecular, the active component of the Avastin and got it FDA approved because the drug company wanted to be able to charge more for it. So the Lucentis, which is essentially the same exact thing as the Avastin, is FDA approved for diabetic macular edema. But it's about $2,200 per patient or per treatment as opposed to about $200. There is assistance for patients who qualify. So insurance companies will pay for the cost, but the copays can be high. So there are assistance for the copay programs as well. And then the other anti-VEGF drugs is Eylea, which works similarly, but is a little bit different, but also targets the VEGF drugs. Just like the other drugs, it was also approved for wet macular degeneration and vascular occlusions first, and now is used in diabetics. And this was approved for diabetic macular edema back in September of 2014. This recommended dosing is, they say on their package insert, is monthly for 5 months and then every 2 months for maintenance. In practice, most people will kind of just play it by ear and do it as needed. Every patient responds very differently. And then usually we'll use this drug after Avastin or Lucentis maybe aren't working quite as well or as quickly as we'd like, especially if you have not yet had cataract surgery or have glaucoma, and we'll kind of discuss why that's the case in a minute here.
So we do have a couple of more questions that popped up, Dr. Dhoot.
Okay.
One of which is, can you kind of comment or talk a little bit about PAMM or paracentral acute middle maculopathy?
Sure. So that's a syndrome that's not associated with diabetics really at all. There's a group of conditions called white dot syndromes that I don't really want to get too much into right now because it's kind of unrelated to the diabetes. But it's a condition that we see in some people who have kind of these weird visual disturbances, for lack of a better term, where they can see some flashing, and sometimes they have a big blind spot that they can't see out of. And we're not 100% sure what causes it, and the treatment is not, the treatment isn't great, just because we don't know exactly what causes it. But it is something that we see in these what we call white dot syndromes.
And then one more question with regards to the VEGF drugs. And this is a good question. You noted that with Avastin, you're being re-injected or repeated that every between 4 to 8 weeks. Is it the same with Lucentis as well? Is it just as often, or does that differ?
So very good question. The drugs usually we say last about 4 to 8 weeks, the anti-VEGF drugs. And so yes, but they go away at different lengths in different people. So what works for one person may not work for other people. So it may be that some person needs steroids and laser and Avastin every single month, and some person can have one Lucentis every 4 months. And so that's why it's really difficult for us to have a blanket algorithm treatment for all diabetics, because every eye and even every person is just different. But yes, for in general, the anti-VEGF drugs last in the eye for about 4 to 8 weeks. And the steroids, which I'm going to talk about in a second, do last a little bit longer, which is one of the appealing things about the steroids. So which drug should we use? The efficacy is similar in most patients. After all, Lucentis is basically made from Avastin. In general, we try to base the decision, at least first line, on out-of-pocket expense to the patient, because some of these drugs can be really expensive and the copays can add up pretty quickly, especially if you're getting monthly injections. There's some insurances that make us start with Avastin and prove to them that the Avastin is not working before we're allowed to advance to brand drugs. So in those patients, it's takes the decision making out of our hands. And then for patients that don't have insurance, there are programs for Lucentis and Eylea patients where they'll actually provide the drug for free, or Avastin. It's about $92 to cover the cost of the drug if the patient were to pay out of pocket. So now steroids. Steroids have also been shown to reduce macular edema. And we think, like I was talking about, with the reduction of inflammation, that leads to the blood vessels becoming less leaky. And we have 4 choices. The Kenalog, which is not FDA approved for use in the eye, but is still used nonetheless. Triessence, which is basically preservative-free triamcinolone or Kenalog, and that one is FDA approved. Ozurdex, which is a dexamethasone implant that slowly releases steroid. Or Eluvian, and the Eluvian is actually a 3-year implant. So it's either injected around the eye or directly into the eye. Obviously, injecting it into the eye is going to be more effective because it gets the drug to the back of the eye where it needs to be. And Kenalog is about $150 per treatment, since we were just comparing all of the other costs. Triessence is about $250 per treatment, and the difference between those is kind of unclear. So the advantages are similar to the anti-VEGF drugs. No laser scars, can provide a dramatic reduction in edema, and treat large areas of swelling. Also easily done in the office. And the duration of action is greater than the anti-VEGF drugs, which last about, they can last about 3 months at the minimum. And then the steroid implants work really well if you've had vitrectomy surgery. So what are the disadvantages? It's invasive. You have to use a needle just like the other drugs. There's a 10% chance that the eye pressure can go up, and that can cause glaucoma if left untreated. Excuse me. It's usually temporary and treated with drops, though. And it rarely requires surgery to control. About a 1 in 5,000, 2 to 3,000, depending on the study you look at, chance of infection. And that's very rarely can result in permanent vision loss. Improvement may be temporary, just like the other drugs. And then the increased intraocular pressure and cataract progression is common. And that's why we talked about using Eylea in patients who already have pressure issues or have not yet or don't need cataract surgery quite yet. Excuse me. And the injections may need to be repeated. So if there's a small area of edema, we can try an anti-VEGF drug. We can try focal laser. If there's a large area of edema, then probably need to go more towards the injections. And then honestly, I think diabetics in general tend to do well with a combination of treatment, whether it be a combination of laser and anti-VEGF and steroids. And then, yeah, we talked about the combination. And then obviously we have this discussion with the patient and, you know, devise a very specific plan for them. But anti-VEGF therapy has pretty quickly become the primary treatment over the last 6 to 8 years. So Ozurdex is the first steroid implant, and it's like the size of a grain of rice. This is next to a baby aspirin, so you can see it's very tiny. It's like a little cigarette that sits in your eye and releases steroids slowly for about 3 to 6 months. It was previously approved for vein occlusions and posterior uveitis, and then was approved for diabetic macular edema in June of 2014. And initially they said, hey, don't do it in patients who haven't had cataract surgery. And then later they said, okay, you can do it on anybody, but just let them know it may make their cataract grow. Advantages is it's the same as other steroid injections, plus it lasts longer. It's a little pellet, so that's less annoying to the patient than Kenalog or Triessence, which is basically just a cloud of white steroid that we inject, and so it can be really distracting to look through. And it's a slower, more consistent release of drug. In patients who've had vitrectomy surgery, the Ozurdex works better than the Kenalog, Triessence, or the anti-VEGF therapy. And the disadvantages, it's a bigger needle, so it can be a little bit more uncomfortable, although we do numb you up a little bit more. And so there's always a thought that there's maybe a slightly higher risk of infection. And it's more expensive. It's about $1,200 per injection. The newest treatment is something called Eluvian. And this is the Eluvian next to a grain of rice. So it's very, very tiny. It is a 25 gauge inserter, so it's a smaller needle than the Ozurdex. It was approved for diabetic macular edema in September of 2014, and this drug lasts in the eye for 3 years. So great, why don't we just give it to everybody? It lasts for 3 years. Well, it can be kind of risky because what if your pressure goes up or it doesn't work very well and then it's stuck in your eye for 3 years? So we really want to make sure that the steroids work well for you and you would be a good candidate before we put something so permanent in the eye. It's the only truly long-term therapy on the market. So the disadvantages, like we talked about, it can cause elevated intraocular pressure and cataract like any other steroid. So we have to try another steroid in the eye first and see that you don't have any increase in your intraocular pressure before we go ahead and inject the Eluvian. If you've had an elevated intraocular pressure that we needed to be treated and we put this in, there may be a higher risk of requiring glaucoma surgery. This drug is almost $9,000 per dose. And it's not always successful as monotherapy. I tell my patients it's kind of like your baseline insulin. It kind of works really slowly in the background, but oftentimes we have to supplement with injections of other drugs. And then surgery in really advanced cases, we basically remove the vitreous jelly that could be pulling and causing kind of a mechanical swelling, contributing to the macular edema. This is an example of a patient who has a lot of macular edema here, lots of cysts. And this right here, this line up here is the back of the vitreous jelly. And you can see it's actually physically tugging on the macula. So there's a component of mechanical traction here. So for example, it may get a little bit better with injections, but this mechanical tugging won't go away. And so this is a patient that would benefit from surgery, going in, removing this vitreous jelly and severing that adhesion to reduce the physical traction. This is another patient that had macular edema, also from diabetes, also what we call an epiretinal membrane here, which is this line at the very top. And they had surgery where we went in and peeled that epiretinal membrane, and you can see their macular edema got much, much better on the bottom picture here. And so if there's any physical stimulus causing the macula to be swollen, the injections themselves are not going to be enough to control the edema. Disadvantages is, of course, it's surgery, so it's more invasive. There's a risk of infection with surgery as well. And there's a risk of a retinal detachment as well anytime we go in to do surgery. So obviously we like to leave surgery as a last resort. Surgery will also cause cataracts to progress. And, then there's always, well, does this actually improve vision? If there's been significant ischemia, for example, we got rid of this huge cyst, but does it actually improve vision? And that's something that's still kind of controversial. Cataract surgery. So this is the lens. Diabetic retinopathy can basically cause your cataract to develop a little bit faster as well. And all patients with diabetic retinopathy should be evaluated by their ophthalmologist prior to cataract surgery to make sure the bleeding is under control in the back of the eye before going in to do surgery. There's a higher risk of macular edema after cataract surgery if you have diabetic retinopathy. All right, so now switching gears, any questions, Michael? Are we good?
Not as of the moment. Nope, we're all good.
So we're going to switch a little bit to talk about the more advanced stages of diabetic retinopathy, the proliferative stages. So if you remember, I mentioned earlier, proliferative diabetic retinopathy is when new blood vessels start forming and growing up into the vitreous cavity. And this is as a result of having really severely damaged blood flow to the retina. The vascular endothelial growth factors, those anti-VEGFs, those also help with the ischemia and help make the new blood vessels go away. So they're helpful in preventing proliferative disease as well. This neovascularization can arise from the optic nerve, in which case we call it NVD, or neovascularization of the disc, or anywhere else on the retina when we call that NVE, or neovascularization elsewhere. The neovascular vessels, they erupt through the retina and they start growing up into the vitreous jelly of the eye. This is a patient here who has proliferative diabetic retinopathy. This big red area here is actually bleeding into the vitreous jelly, something that we call vitreous hemorrhage. And the hemorrhage can accumulate in the vitreous cavity or in what we call the subhyaloid space, which is basically trapped by the back side of the jelly. And so essentially it's also in the vitreous cavity. So basically the retina in proliferative diabetic retinopathy is starved for oxygen because it's not getting the good blood flow. The retina in turn responds by producing this signal called VEGF that's saying, hey, we're not getting good blood flow, we're not getting good blood flow. So then the retina starts making its own new blood vessels. That's what we call neovascularization. Those new blood vessels are not healthy, and when we see evidence of them, we need to start treatment to make those new blood vessels go away. This here on the left is an example of neovascularization elsewhere. And here you can see all these curly blood vessels coming directly from the optic nerve. And so that's neovascularization on the disc. So like I said, those new blood vessels can bleed into the vitreous, causing vitreous hemorrhage or subhyaloid hemorrhage. And if you have a vitreous hemorrhage, you will notice that you're seeing dark floaters. And if it's a ton of blood, then you'll have a total loss of vision if the blood is completely obscuring your ability to see out. So in that case, it would look like this, just like this patient can't see out anything. I can't see anything into the eye because there's so much blood and it obscures my view in as well. This is a fluorescein angiogram. If you remember, we talked a little bit earlier about a patient that has proliferative disease. And you can see there's big black areas here. And these are all areas that are not getting good blood flow. That all should be white back there, but it's all black because it's not receiving good blood flow. That's why these new blood vessels up here and these new blood vessels over here are starting to kind of run rampant. So going back to that person who asked about glaucoma earlier. So later on in the proliferative diabetic retinopathy stage, you can get what we call neovascularization of the iris or of the angle. And what that means is there's so much damage to the blood flow in the eye that these new blood vessels start growing on the colored part of the eye and into the drainage canal of the eye down here. And it can basically close off the drain in the front of our eye, and the eye pressure can shoot up really, really high. It can be very painful, and it can cause blindness from damaging the optic nerve from such high blood pressures. The other thing that can happen is if these new blood vessels are not noticed and they kind of just keep growing and keep proliferating, they can actually form sheets of scar tissue and cause the retina to detach. And that's called a tractional retinal detachment. And this is a picture of kind of an old one, but all of this here, these are just sheets of new blood vessels that kind of proliferated and started to detach the retina. And I have better pictures here. This one is obviously much more severe. At this point, this is something that needs to be repaired in surgery and has very poor visual outcomes. So treatment of proliferative diabetic retinopathy, same sort of thing, treating the blood sugar, treating the blood pressure, cholesterol, all the stuff we talked about earlier. Laser is the mainstay of treatment. And you can do injections too, but those are usually adjunct treatments. Usually we will give the injection first to kind of rapidly help with the swelling and the neovascularization. But again, remember, those injections wear off. And so then the permanent treatment is the laser that we do afterwards. And the laser is a permanent laser. And sorry, is a permanent effect. Complications in proliferative disease, like we talked about, tractional retinal detachments, retinal tears, and sometimes you can get a combined what we call regmatogenous and tractional retinal detachment from the scar tissue just really quickly contracting and ripping the retina from the back wall of the eye. And most of these need vitrectomy surgery. So this laser treatment is different than the laser that we did for the macular edema. This laser is called pan-retinal photocoagulation, and it's not in the center. Here we laser the peripheral part of the retina that's basically dead anyways because it's not getting good blood flow. And by lasering that peripheral retina, we're destroying the retina that's creating those signals asking for new blood flow, and then slowly those new blood vessels will go away. And by doing this laser treatment, we reduce the risk of vitreous hemorrhage and neovascular glaucoma by about a half at 2 years. So like we said, the mechanism of action is reducing those new blood vessel growth. So basically, the bottom line is the PRP treatment, it destroys the peripheral retina to save the central retina. And it's kind of like the robbing Peter to pay Paul analogy. So this is what the laser looks like. It's not in the center here like the focal macular laser. It's out here in the peripheral part where your retina is dead anyways. And this is a patient who had a lot of pan-retinal photocoagulation therapy, and it's come all the way up to here. But you can see your optic nerve and the macula still look good. So this patient probably has very good central vision. They have no peripheral vision, but their central vision was saved by doing such extensive laser. Sometimes if there's blood that's not going away in the vitreous hemorrhage, then we need to go in and surgically remove the blood, and we can do laser at the time of surgery as well. Like I talked about earlier, if there's a traction retinal detachment, that's something that needs to be repaired surgically as well by a retina surgeon. So there's been a lot of hype recently about this study that came out called Protocol S. And they said, hey, listen, instead of lasering all of these patients and you're causing peripheral vision damage, why don't we just inject them with medicines every single month? Yes, the injections wear off, but we can just keep giving them every single month or every 2 months or every 3 months. And that way we don't have to laser and destroy the peripheral retina. And they did a study that said that the vision is equivalent in groups if they get injections every month versus PRP laser. So, well, should we start giving everybody injections then for proliferative diabetic retinopathy? PRP causes peripheral vision loss. It can make the macular edema worse. It can make night vision worse. So maybe we should give everybody injections. On the flip side, each injection carries a risk of endophthalmitis. So if you're getting endophthalmitis is a serious infection. And so if you're getting an injection every single month, I mean, cumulatively that adds up. Well, laser doesn't have any risk of infection. And the injections work for about 4 to 6 weeks. So theoretically, we'd have to give somebody an injection every 4 to 6 weeks, pretty much for the rest of their life. And this is probably the most important, is a lot of our diabetics, like it or not, I mean, if they have bad eye disease, they probably also have bad kidney disease. And maybe they also see a podiatrist for their feet. And maybe they also see a cardiologist for their heart disease and a neurologist and an endocrinologist. And all of these doctor visits, they add up. And so, you know, sometimes it can be difficult to keep all of the appointments. And so if we lose them and aren't able to get an injection in, they could potentially regress and even lose the eye. And so if we do the laser treatment, that's a permanent treatment. So even if we don't see them potentially for months on end, then the laser should hopefully theoretically keep them from getting worse. And then, you know, the cost of giving an injection every 4 to 6 weeks certainly adds up as well. So what's the bottom line? I think the best treatment is likely a hybrid, just like everything else, customized to the patient and their needs and their ability to pay and come in for appointments and what they do on a day-to-day basis. Each person and even each eye is very different, and your retina doctor can work closely with you to build a very tailored plan for your specific condition. And again, follow-up is absolutely crucial to reduce the risk of irreversible blindness. Sometimes they come to us and it's at the point of no return and there's nothing we can do. And it's one of those things where we're kicking ourselves like, man, we wish we had seen this patient earlier. I'm going to just touch very, very briefly before I open it up to more questions about a couple of other eye things that can happen with diabetics that are not in the retina. So sometimes you can get fluctuating vision due to swelling of your lens with high blood sugars. You can get damage to your optic nerve or diabetic optic neuropathy. You can get cranial nerve palsies, which can cause double vision. So basically the nerves that control our eye muscle movements can get damaged from diabetes and cause double vision. And that's something that we would have to work up as well. And if you have corneal surgery, we know that diabetics don't heal as well as patients who are not diabetic. There are some future treatments that are being looked at, alternate drug delivery system. Maybe we can inject on the white part of the eye instead of into the eye, or maybe give drops, which haven't really proven to reach the back of the eye as we'd like, but certainly we're still investigating. Unfortunately, the studies, like I said, so far have been poor. There were drops that were being evaluated, anti-Vegf drops for wet macular degeneration. They didn't even advance to phase 3 because they just weren't shown to be have any efficacy. And then maybe extended dosing for particles that may allow the anti-Vegf drugs to stay in the eye for longer. And then other steroid or steroid-like implants. So at this point, these are my 2 little kids. I have a 5-year-old and a 3-year-old. And so I want to open it up to any questions that I can answer for anybody.
Somebody actually just submitted one right on time. I've heard that virtual ophthalmology or teleophthalmology, what about its use for diabetic retinopathy? How would that work?
Yeah, so that's a good question, and they've actually looked at that in a lot of primary care offices are looking at, can they get a camera that doesn't need to dilate the eye and can kind of look in and see if there's bleeding. You know, nothing suffices for an eye exam. In my opinion, a dilated eye exam gives us much more information. Even when we take pictures in our office, it's not a substitute for a dilated eye exam. There's a lot that can be missed on pictures. So, you know, I think in like maybe third world countries where there's not access to physicians, it's, you know, it's the only alternative that we have. But I don't, you know, I think it could be used as an adjunct, but I don't think it is ever going to get to the point where it's going to completely replace dilated eye exams.
This time, like Dr. Dhoot said, if anybody has any last questions here, you're more than welcome to type it in, as we just received one more. Are diabetic retinopathy and macular degeneration related in any way?
No, not at all. We use very similar treatments for both of them. So all of those anti-VEGF therapies are also used for macular degeneration patients, but totally different disease process.
One more chance, if there's anybody that wants to submit one last question for Dr. Dhoot before we sign off tonight. If not, you can always go ahead and email you can always email myself, myork@harvardeye.com, or our marketing team, and we'll be happy to pass those questions along to Dr. Dhoot and get them answered for you. So on behalf of Dr. Dhoot, if nobody has any last questions, we appreciate everybody joining tonight, and have a wonderful rest of your evening.
Thank you, everyone. I hope
Take
to
care,
meet you all
everyone.
soon. Bye-bye.